Hello, hi, good afternoon, everybody. And it's a pleasure to welcome you all to this Uro-Oncology session of 20th Shaukat Khanum Cancer Symposium. I'm Dr. Zubair Shima, consultant urologist here in Shaukat Khanum Cancer Symposium and Research Center. We have put an exciting program over the next 90 minutes or so. We've got 4 speakers internationally as well as from Pakistan who are going to cover the breadth of the urological cancers. So it's my pleasure to introduce my first speaker to you first, and that is Professor Robert Jones, who is a professor of clinical cancer research, University of Glasgow, UK. And he's going to take us through the updates in the bladder cancer. So what we'll do, we'll start with his video, and I will encourage the participants to please drop in your questions as the talks go along in the chat box or the question answer box, so that the panelists can take those questions and answer them as we go along. We'll probably have a question and answer session at the end as well. So over to you, Professor Robert Jones.
Hello, my name is Rob Jones and I'm a medical oncologist from Glasgow in the UK. It's a great pleasure to be invited to speak to you about updates in bladder cancer today, and I'm only sorry that I can't join you in person. These are my disclosures. So I'm going to cover a few key areas of recent update in this area. In particular, we're going to talk about advanced urothelial cancer. We're going to speak about maintenance avelumab, and then third line enfortumab vedotin, and then a little bit about some emerging treatments in this field, in particular third-line erdafitinib, first-line IO-IO combinations, and first-line enfortumab vedotin combined with pembrolizumab. And then I'm going to talk a little bit about perioperative treatment of muscle-invasive urothelial cancer, particularly about the adjuvant treatment of upper tract disease with chemotherapy, and emerging data on the adjuvant treatment with immunotherapy. So first, let's talk about maintenance avelumab. Now, there have been a number of attempts to try and successfully combine chemotherapy, platinum-based chemotherapy, with immunotherapy as a first-line treatment. In particular, there are these 2 large global randomized phase 3 trials, the IMvigor130 trial, which explored chemotherapy with or without atezolizumab, and it also included an atezolizumab alone arm, and a similarly designed study, Keynote-361, of chemotherapy with or without pembrolizumab, again with a monoagent pembrolizumab arm. Now, to cut a long story short, neither of these trials is yet practice changing. These are the headline results of the atezolizumab trial. So this is chemotherapy in red, chemotherapy plus atezolizumab in blue. This was a positive trial for this co-primary endpoint of progression-free survival, but the co-primary endpoint of overall survival has not yet been reached. So you can see there's an 18% reduction in the risk of progression in favour of the combination arm. Now, the FDA ODAC committee have deemed that progression-free survival alone is insufficient to change practice. And so we still await the results of the overall survival data before concluding whether this is a new therapy to be offering patients. The pembrolizumab trial is a negative trial. Again, co-primary endpoints of progression-free survival in the upper chart and overall survival in the lower chart. And the trial failed to meet either of these co-primary endpoints. And so this was a negative trial. However, there was this third randomized phase 3 trial, which was the Javelin Bladder 100 trial. And this took a slightly different approach. This was for patients who were already receiving chemotherapy, either cisplatin or carboplatin with gemcitabine, and who had either responded or had stable disease after at least 4 cycles of treatment. And these patients were then randomized to receive either maintenance avelumab, i.e. to go on to immunotherapy before they'd progressed, or supportive care alone. The primary endpoints were overall survival in both the intention to treat population and in the PD-L1 positive population. And this is the headline results, the updated headline results of the intention to treat population. And you can see there's a clear statistical and clinically significant benefit in favor of immunotherapy, with patients in the avelumab arm on average living 7.5 months longer than patients in the best supportive care arm, and that equates to a 30% reduction in the risk of death. Unsurprisingly, the PD-L1 positive population was also strongly positive in this trial, with a 40% reduction in the risk of death. By way of interest, this effect was very similar for patients who had received prior cisplatin as it was for patients who had received prior carboplatin. So we can conclude that this treatment is applicable to either group of patients. So in summary from this trial, chemotherapy followed by maintenance of avelumab for those patients who have response or stable disease at the end of chemotherapy is the new standard of care in first-line advanced urothelial cancer treatment. We'll now move on to talk about third-line enfortumab vedotin. So enfortumab vedotin is an antibody-drug conjugate. The antibody targets a protein called nectin-4, which is expressed on the surface of the majority of urothelial cancers. So the antibody binds the nectin-4, which is then internalized into the cell. The internalization then activates the cytotoxic payload, which is bound to the antibody. And this cytotoxic payload then releases a microtubule inhibitor, and that kills the cancer cell. So this is the EV301 trial, which was the pivotal phase 3 trial of enfortumab vedotin. So this is for patients with advanced urothelial cancer who had progressed after at least one platinum-based chemotherapy and one immunotherapy agent. Patients were randomly assigned to either enfortumab vedotin or the investigator's choice of cytotoxic chemotherapy, which could be either docetaxel or paclitaxel or vinflunine. And the primary endpoint was overall survival. This is the headline result presented earlier this year by Tom Poles at the ASCO GU meeting. And you can see here there's a nearly 3-month median survival gain in this third-line setting, equating to a 30% reduction in the risk of death. So we conclude from this trial that enfortumab vedotin is rapidly emerging as the standard of care following chemotherapy and immunotherapy for advanced urothelial cancer. The drug is already licensed in the United States and is currently going through the licensing processes in other jurisdictions. Move on now to talk about third-line erdafitinib. So erdafitinib is an inhibitor, a small molecule inhibitor of the fibroblast growth factor receptor. It's an oral compound, and fibroblast growth factor receptors are molecularly aberrant in a number of common solid tumours. And you can see there is an aberration, either an activating mutation or a gene fusion in about between 15 and 20% of advanced urothelial cancers. So this is the BCL 2001 phase 2 trial. It's a non-randomized phase 2 trial, and all patients had to have one of these molecular aberrations in the fibroblast growth factor receptor. So in other words, it's a selected population. It's only between 15 and 20% of all comers. And the primary endpoint was overall response rate. This is the waterfall plot showing you the changes in tumour size of the patients who took part in this trial. And you can see there's a clear trend towards response in patients, irrespective of whether it's an FGFR mutation or a fusion. This is now rapidly moving forwards in a randomized phase 3 trial. Let's look at IO combinations. So this was the Danube trial. This was one of the first randomized phase 3 trials of first-line immunotherapy in advanced urothelial cancer. This is durvalumab, a PD-L1 targeted antibody, and tremelimumab, a CTLA-4 antibody. So analogous to ipilimumab. It was a 3-arm trial, durvalumab versus durvalumab plus tremelimumab versus standard of care chemotherapy, cis or carbo plus gemcitabine. Now this was a negative trial overall, but there was this intriguing secondary endpoint of overall survival in the durva-tremi population. So this is the primary endpoint shown here, which was in the intention to treat population, and you can see that it is not a statistically significant advantage. However, if we look at the PD-L1 high population, this was a secondary analysis. This this suggests there's quite a strong signal in favor of combination immunotherapy actually being superior to chemotherapy alone. Now, this is not practice changing because this was a secondary endpoint and the trial itself was negative. But the reason to highlight this is that we are very soon expecting the results of the Checkmate 901 trial. Now, in fact, we may have the results of this trial by the time you actually see this recording. And this is a trial which includes that combination of PD-1, in this case nivolumab, and CTLA-4, in this case ipilimumab, compared to chemotherapy. In that randomization at the top. And so, and it also includes a primary analysis in the PD-L1 positive population. And so, in other words, if we can replicate the results seen in the exploratory analysis of Danube, it's possible that this may demonstrate a clear survival advantage for combination immunotherapy over and above chemotherapy. And finally, I want to talk a little bit about enfortumab vedotin, the drug I just showed you in the third-line setting, and pembrolizumab. Now, this was on the left, we have a trial in the first line. This is essentially a phase 2 trial. It's actually a phase 1b trial in the first line setting of cisplatin ineligible patients, given this combination of pembrolizumab plus enfortumab vedotin. And you can see there that nearly all the patients had some form of tumor shrinkage. In fact, the overall response rate was a staggering 73%. Now, of course, we know that response is a relatively easy to get with chemotherapy in the first line setting, but of course the attraction of immunotherapy has always been that duration of response. And the thing that I find most striking about this study is not only is the response rate 73%, but the median duration of response is around about the 2-year mark, which of course is similar to what we see with pembrolizumab alone in the second line setting. So if this is true, we're achieving very high levels of response, but very durable responses. And there's an ongoing phase 3 trial, which is exploring this combination compared with chemotherapy, with co-primary endpoints of progression-free survival and overall survival. And so there's high expectation that this may prove to be a highly potent new therapy to challenge chemotherapy in the frontline setting in advanced urothelial cancer. So let's move on now finally to talk a little bit about perioperative treatment. So the title of my talk was bladder cancer, but I've included in this study of upper tract urothelial cancer. This is a study that we designed and delivered in the UK, the POUT trial. And this was for patients who have upper tract, that is renal pelvis or ureter, invasive, that is T2 and above, urothelial cancer, where the prior standard of care was surveillance. So patients were randomly allocated between surveillance post-nephroureterectomy or 4 cycles of chemotherapy following nephroureterectomy. Now, this was gemcitabine plus cisplatin, although patients who could not receive cisplatin because of a drop in their glomerular filtration rate were permitted to have carboplatin. No other criteria for non-cisplatin fit were included in this trial. The primary endpoint was disease-free survival. Overall survival was a secondary endpoint. And you can see this is a positive trial. This is actually the updated analysis presented earlier this year. It remains a positive trial for overall survival, for disease-free survival. And so we conclude that this is practice changing. However, the secondary endpoint of overall survival, although there's a distinct trend towards an overall survival gain for patients receiving chemotherapy, unfortunately, this failed to show statistical significance. And finally, I want to talk about adjuvant immunotherapy in invasive urothelial cancer. So this is the Checkmate 274 trial. This is a randomized phase 3 double-blind multi-center study of adjuvant nivolumab. So this was for patients with either bladder or upper tract urothelial cancer who had undergone radical resection. They may have received neoadjuvant chemotherapy, but there was no obligation for them to have received neoadjuvant chemotherapy. And it included node-positive patients. Patients were randomly allocated to receive a year's post-operative nivolumab fortnightly or a year's placebo infusion fortnightly. The primary endpoint is disease-free survival in the intention to treat population and disease-free survival in the PD-L1 positive population. Overall survival is a secondary endpoint. So this is the disease-free survival results, and this is a positive trial. You can see there's a statistically significant 30% reduction in the risk of relapse for patients receiving adjuvant nivolumab compared with those receiving placebo. And you can see a more pronounced effect, a 47% reduction in the risk of relapse in patients who are PD-L1 positive. So this is a positive trial. However, we have not seen any overall survival results yet because there are insufficient events to present this important secondary endpoint. And I just draw your attention to this subgroup analysis in light of the study I've just shown you, the POUT trial. Although there are no statistically significant outliers, I think we do have to raise the question as to whether or not this does set a new standard of care of immunotherapy in the upper tract disease, particularly in a trial where the control arm did not include chemotherapy, which the POUT trial has already established as a standard of care in upper tract disease based on disease-free survival. And I think it is questionable whether it is actually valid to include these upper tract patients in a mixed study with bladder cancer. So, in summary, maintenance of avelumab following response or stable disease after first-line chemotherapy is a new standard of care as it prolongs survival. Secondly, new immunotherapy combinations are showing great promise in the first-line treatment of advanced urothelial cancer, particularly that combination of ipilimumab plus nivolumab. And thirdly, enfortumab vedotin is a rapidly emerging standard of care in the third-line setting with a positive phase 3 study showing survival gain in that third-line setting. I think adjuvant chemotherapy is the standard of care after nephroureterectomy for invasive upper tract urothelial cancer, but adjuvant immunotherapy after cystectomy may become standard of care, but I believe that we really need to see maturity of the overall survival findings. And that's the end of my talk, and I look forward to the opportunity to answer your questions at the end of the session. Thank you very much.
Thank you very much, Rob, for sharing with us these extremely informative, exciting, and practice-changing aspects of bladder cancer management. And I am highly impressed by the ease and beauty with which you have instilled these wonderful concepts into our minds. And this shows the amount of immense experience that you have in research. Our next talk is going to be on high-dose therapy and autologous stem cell transplant by Dr. Jeff White. Dr. Jeff White is a highly committed consultant medical oncologist at Beatson, West of Scotland Cancer Centre since 2004. He is also an honorary clinical senior lecturer at the University of Glasgow. His clinical interests include the management of sarcoma, germ cell cancers, and care of young adults and teenagers with cancer. Dr. White was formerly the clinical lead of the Scottish Sarcoma Managed Clinical Network and was on the board of trustees for Sarcoma UK from 2013 to 2020. He has a leading role in the management of relapsed germ cell tumors from all over Scotland and is actively involved in providing peer support, management of complex treatments like high-dose therapy and autologous stem cell transplant in relapsed germ cell tumors, and also in the clinical trials. His informal activities also include annual education day in October, and he is also actively involved in joint clinical papers in peer-reviewed journals and has acted as principal investigator in various germ cell clinical trials run by UK's NCRI, TBI, and Germ Cell Clinical Studies Group. Over to Dr. Jeff White, please.
I would like to thank the organisers of your virtual symposium for asking me to give this talk. My name is Jeff White. I'm a medical oncologist at the Beats of Western Scotland Cancer Centre in Glasgow. As many of you will know, there are a few indications for high-dose chemotherapy and peripheral blood stem cell transplant as part of the management of solid cancers. In Glasgow, along with colleagues from the bone marrow transplant unit at the Queen Elizabeth University Hospital, we act as a single centre for the whole of Scotland for patients with germ cell cancer who are refractory to standard therapy and require this as part of their management. To deliver this talk, I'm going to try and use a real case to illustrate how high-dose chemotherapy can have a role, and also look at the background to this therapy, including prognostic factors. We've performed our own audit, so we'll look at our methodology of that, summarising the efficacy, acute and long-term toxicity, and I'll provide you with a series of references. The case is one of a 31-year-old man who was previously fit and well. He was a heavy smoker who presented to another cancer centre with hemoptysis. His chest X-ray is shown here with multiple pulmonary metastases, and these were confirmed on CT scan. Ultrasound confirmed a right testicular tumour, and alpha-fetoprotein was 790, HCG 4,980, LDH 3,200, i.e. greater than 10 times the upper limit of normal. A diagnosis of metastatic non-seminomatous germ cell cancer was therefore made. Unfortunately, the treating clinician failed to recognise that the LDH level put him into the IGCCG poor prognosis group, and therefore is relatively undertreated with just 4 cycles of etoposide and cisplatin. His HCG never normalised, and he was left with residual nodules at the end of his chemotherapy. An orchidectomy performed a couple of weeks after completion of chemotherapy showed necrosis with no viable germ cell elements. However, 2 weeks later, he was referred to me as his HCG had gone from 71 to 900. At that time, he was well with a good performance status and no residual toxicity from his first-line treatment. We performed a PET scan, which showed increased FDG uptake in several areas of the lungs. We also did an MRI scan of his brain to exclude CNS disease as a sanctuary site. We were taking part in international randomized studies of standard salvage chemotherapy with TIP, i.e. Taxol, ifosfamide, and cisplatin, or induction chemotherapy with Taxol, ifosfamide, followed by 3 cycles of high-dose chemotherapy and peripheral blood cell rescue with carboplatin and etoposide induction. The patient was randomized to standard treatment and he received 4 cycles of TIP, which he tolerated exceptionally well. We did a peripheral blood stem cell transplant, a collection of cycle 2 of the TIP, and his HCG rapidly normalized. We've seen at his local hospital around a month after completing therapy, and I was not made aware of the fact that his HCG had already gone immediately back up to 200 with a normal AFP and LDH at that point. Thus, he has partial platinum sensitivity. In this situation, with good performance status, the only chance of cure was to offer high-dose chemotherapy and peripheral blood stem cell transplant. As our colleagues in the bone marrow transplant unit were unable to offer a bed immediately, we had to bridge the gap somewhat by using the palliative regime of gemcitabine and oxaliplatin whilst he underwent workup for high-dose chemotherapy. He underwent 2 cycles of high-dose chemotherapy with carboplatin and etoposide and peripheral blood stem cell reinfusion. Once again, he tolerated this well. I'm pleased to say 2.5 years later, he remains in remission with a normal HCG. A residual nodule was removed via video-assisted thoracoscopy, and this showed no viable malignancy. The patient does require hearing aids and has a mild degree of peripheral neuropathy, but this doesn't stop him attending the gym and working as a metal fabricator. I think this case provides some useful clinical context for the background and evidence base for the use of high-dose chemotherapy in refractory germ cell cancer, and I'll now briefly try and summarize this and then look at our own retrospective audit. So around 20% of cases who've previously been treated with cisplatin for advanced germ cell cancer will relapse. There are 2 broad approaches to salvage therapy with standard platinum-based triplets or high-dose chemotherapy and peripheral blood stem cell transplant. And as yet, we don't know which is better. An important thing to say is that this is a heterogeneous group of patients, and it's important to exclude particularly those late relapses that occur after 2 years from prior chemotherapy, as these should be managed surgically. There is also a clear need for accurate prognostication due to the heterogeneity and rarity of the situation. And Launch published a large retrospective study of nearly 2,000 patients who have progressed after first-line platinum-based therapy. The International Prognostic Facts Study was published in JCO in 2010. The factors in the study are based on prior response, the progression-free interval, tumor markers at the time of salvage therapy, and liver, bone, and brain metastases. These scores are aggregated into 5 groups, which have significantly differential survival outcomes, as can be seen on this slide. Although this is a non-randomized study, it is large, and subgroup analysis would suggest that patients treated with high-dose chemotherapy had superior outcomes in terms of progression-free and overall survival compared to those treated with standard dose treatment, with the exception of overall survival in the low-risk group. In the next 2 slides, those treated with high-dose chemotherapy are represented in the yellow lines, and those treated with conventional dose chemotherapy are represented in the blue lines. So here we see the progression-free survival across all 3 groups. And here is the overall survival. So when a patient relapses with germ cell cancer, we have 2 broad approaches. Conventional dose chemotherapy would include triplets of platinum-based therapy alongside Taxol, ifosfamide, etoposide, or vinblastine. These regimes will cure approximately 50% of patients, and toxicity is predominantly hematological and neurological. TIP is the most frequently used salvage regime, and it's based on the in vitro synergy of Taxol with germ cell lines which were resistant to cisplatin. TIP generates durable response in around 63 to 73% of cases. This variation is likely due to heterogeneity of patients entering different clinical trials. Again, the toxicity is largely myelosuppression, with additional toxicity in the form of neuro and nephrotoxicity. There is no randomized data comparing these platinum triplets. The rationale for high-dose chemotherapy is that germ cell cancers are relatively chemosensitive, rarely infiltrate the bone marrow, and predominantly affect young adults with relatively low comorbidities who can tolerate the intensity of such treatments. Early clinical trials, however, were complicated by significant toxic death rate. However, the introduction of GCSF has reduced this down to less than 3% of episodes. Early attempts for high-dose chemotherapy also included multiple drugs, in addition to platinum and etoposide, drugs like Taxol and cyclophosphamide. More recent studies have suggested benefit of focusing on the 2 most active drugs, namely carboplatin and etoposide, with multiple cycles of high dose followed by peripheral blood stem cell rescue. An example of this is Larry Einhorn's paper from the New England Journal of Medicine 2007, which was a retrospective study of 184 patients, yielding a complete response rate of 63% with a median follow-up in 4 years. There is little randomized data comparing high-dose chemotherapy with peripheral blood stem cell transplant with that of standard triplet-based platinum chemotherapy. However, there is one example. This is the IT94 study. Patients were randomized to either 4 cycles of VIP, which could be ifosfamide, etoposide, and cisplatin, or vinblastine, ifosfamide, and cisplatin, versus 3 cycles of these regimes, followed by a high-dose chemotherapy with carboplatin, etoposide, cyclophosphamide, and taxane, the carbopec regime, with peripheral blood stem cell rescue. There was no significant difference between the 2 arms in terms of outcomes and response rates, but single cycle of high-dose chemotherapy was more toxic, and was associated with a higher death rate. It's worth pointing out that more modern approaches use multiple cycles of high-dose chemotherapy. So the current global randomized phase 3 clinical trial is called the TIGER study. This randomized patients to TIP, 4 cycles versus 2 cycles of induction with Taxol and ifosfamide peripheral blood stem cell collection, followed by 3 cycles of high-dose chemotherapy with carboplatin and etoposide and peripheral blood stem cell reinfusion. The primary endpoint is overall survival, and this was the study that our patient was randomized to. The background of this experimental arm is based on a phase 1/2 study by Darren Feldman, published in JCO in 2010, demonstrating a 52% overall survival with a median follow-up of 5 years. Recruitment of this study has been significantly impaired by the global pandemic, and indeed in Glasgow, recruitment is still suspended due to the backlog of hemato-oncology cases requiring transplant beds. However, the study is 75% accrued globally. So whilst we await the results of the TIGER study, we felt it's important to retrospectively review our own case series in Scotland and compare them with historical data sets. The aim was to look at our outcomes for high-dose chemotherapy and stem cell transplant from 2001 to 2016. I had intended to do a formal update of the survival analysis as of now, but unfortunately time has run away with me. Our methodology was to use the bone marrow transplant database, which is linked with the European bone marrow transplant database, to identify patients who'd received high-dose chemotherapy and stem cell reinfusion for this particular indication. A combination of electronic and paper-based records were searched for patient disease characteristics, the actual management, acute and late toxicities, and of course survival. The first slide here summarizes the characteristics of our patients. As one would expect, a significant number were male. However, given the outcomes for female germ cell cancer are more challenging, it's perhaps not surprising to see some of them required salvage therapy. Also, as not expected, the predominant histological type was non-seminomatous or mixed germ cell cancer. And as one would expect, most patients were initially an IGCSE1 poor risk group. In fact, on several occasions over the last 15 years, we've noticed that we see more than our fair share of poor prognosis patients in the west of Scotland compared to other published data sets, possibly as a result of deprivation, etc. This slide summarizes the first-line treatments. For those of you not familiar, CBOT-BEP is a dose-dense regime with equivalence to BEP in the first-line management of poor prognosis metastatic germ cell cancer. Salvage treatments can be used in a heterogeneous group of patients, although 83% of our cases had documented relapse or progressive disease. We did treat 17% of our patients who went on to high-dose chemotherapy directly after first-line treatment on the basis of perhaps inadequate response to first-line treatment, such as finding active viable cancer in resected specimens. However, and importantly, applying the international prognostic factors, 57% of our patients were in the high or very high risk groups, with expected 2-year progression-free survival and 3-year overall survival as highlighted here, i.e. very poor. This slide summarizes our approach to high-dose chemotherapy with induction, mobilization schedules, and then the high-dose chemotherapy. 50% of our patients had a complete or partial response with marker negativity after induction. 28% of patients required additional chemotherapy to mobilize stem cells, though now we use the chemokine receptor antagonist Pulixafor, and this is less of a problem. It should be noted that some of these approaches are quite old-fashioned, using multiple drugs such as carboplatin, epirubicin, Taxol, and cyclophosphamide. But more recently, we've focused on the Einhorn carboplatin etoposide regime, with 66% of our high-dose cases receiving this, and 75% of those receiving 2 cycles. So there were 29 high-dose chemotherapy episodes. The mean interval between sequential high-dose chemotherapies was 8.6 weeks, which is significantly longer than recommended in the TIGER protocol at 3 to 4 weeks. This is due to capacity issues in the bone marrow transplant unit. Importantly, those patients who had done well with high-dose went on to receive surgery. 10 of them did, and encouragingly, 50% of them had differentiated teratoma and 50% had no viable malignancy. The responses to salvage therapy, 67% had no evidence of disease, 17% had persistent tumour markers, although 2 of these have gone on to remain stable and therefore presumed to be in remission with borderline marker elevation. 1 patient had progressive disease and 1 patient had a stable response to high-dose salvage therapy. In terms of survival, at a median follow-up when this was last formally analysed in September 2017, 61 months, 5 or 28% had died. 1 of these was an acute death during therapy with an acute intrapulmonary hemorrhage post-high-dose chemotherapy, and 4 others have relapsed due to progressive disease after high-dose. This leads to our overall survival curves shown here, with a 2-year overall survival rate at 69% and a 2-year progression-free survival at 62%. Although I've not formally analysed these, there's been no further deaths or progression since these were analysed in 2017. And in fact, there is this concept in lower stage germ cell cancer of conditional survival, i.e. once you get to about the 2-year mark, there is a relatively low rate of subsequent events. In terms of acute toxicity, evaluable from the 29 high-dose cycles, as one would expect, septic episodes were very frequent, and mucositis was prominent, with 16 cases requiring subcutaneous medication in the form of syringe driver, ranging from 3 to 5 days out of each transplant episode, with 10 of these patients going on to require nutritional support in the form of either nasogastric or parenteral nutrition. And our bone marrow transplant colleagues comment that some of our induction regimes seem a bit more problematic with mucositis than some of their hemato-oncology regimes. 2 patients required critical care, and there was 1 toxic death mentioned earlier, a man with intrapulmonary hemorrhage post-high-dose chemotherapy and significant deterioration in liver function. He was from a non-Caucasian background, and I wonder if there's some racial difference in how patients handle these high-dose procedures. In terms of longer-term toxicity, we looked at this at least a year by looking at the medical records. Unsurprisingly, this is predominated by neuro and O2 toxicity. So in comparison of our outcomes with the International Prognostic Group and a group from Yorkshire, Sheffield and Leeds, you can see the overall survival and PFS are equivalent, if not somewhat better. Although obviously there's marked heterogeneity in these series, but I would like to stress that ours did have a significant proportion of patients who fell into that high or very high risk group. So in conclusion, our outcomes are comparable, but note the heterogeneity of our patients. We were unable to deliver high-dose chemotherapy sequentially in an appropriate time interval. The toxicity is as described, and as one would expect, there is a significant mortality associated with this, although this is within the published range. And there is significant long-term toxicity, and it's important that patients are supported in this because many of the clinicians will not understand this long-term toxicity. As yet, it's unclear whether high-dose chemotherapy is better than standard dose conventional chemotherapy, and we await the results of the TIGER study to try and answer this question. I'd like to finish by thanking colleagues from Hemato-Oncology, particularly the bone marrow transplant data management team, and Uni Tan, who was a registrar in medical oncology at the time she did this initial analysis, but is now one of our consultants. Thank you very much for your attention, and I've provided some references for you at the end.
We can't hear you, Dr. Maria. Can you just unmute your mic, please?
Sorry. Thank you, Jeff, for such an informative, brilliant, and impressive talk. I think all our colleagues who have attended your session will definitely be thinking about changing their management in relapsed germ cell tumors, and will be thinking about adopting this approach. And I look forward to the day when we at our center will also be able to start high-dose therapy and autologous stem cell transplant in these relapsed germ cell tumors. Thank you very much. Over to Dr. Zubair, please.
Thank you very much, Dr. Maria. Fascinating talks by our first two speakers. So we'll carry on with our rest of two talks. It gives me a great pleasure to introduce our next speaker, Dr. Wade Sexton, who is a consultant urologist at Moffitt Cancer Center, Florida, USA. Thank you very much for being with us today, Dr. Sexton. He's well known in the world of the Uro-Oncology in States, has done a lot of work with the forces there as well. I'm sure it's pretty early in the morning there. So again, thanks for being with us. His special interests are renal cell cancer, prostate and the bladder cancer, as well as the complex RPLNDs. That's what we are looking forward to hear from him today. So his talk is going to revolve around tips, techniques, and the indications of RPLND, which is retroperitoneal lymph node dissection. So without wasting any time, we'll continue with his talk. And again, to people who have joined us, I'll ask them to drop the questions in the question answer box so that we can answer them as we go along. Over to you, Dr. Sexton.
I would like to thank the organizers of the Cancer Symposium for the invitation to speak about testicular cancer. In thinking about this topic, I thought that I would focus on relapse on active surveillance, and then even relapse or recurrence following systemic therapy. So let's first look at active surveillance patients with seminoma and non-seminoma. Of course, the majority of patients that you and I see diagnosed with stage 1 disease have seminoma. And of the seminoma patients, the significant majority, we're going to decide active surveillance as the best management strategy. About 30% of patients with non-seminoma have stage 1 disease, and many of those are candidates for active surveillance as well. Now, for stage 1 seminoma, there are a number of clinical and pathologic risk factors that we've looked at over time. Tumor size appears to be the most important risk factor out of these three, but traditionally validation studies have been a bit controversial, and the presence or absence of these risk features likely impacts the type and duration of surveillance more so than you and I deciding who we should treat and who we should not treat. That's particularly true with stage T1 seminoma. And here's some data from Princess Margaret Hospital in Toronto, looking at stage 1 seminoma patients. And we know now that the T1 patients are stratified to T1A and T1B based on the presence of small versus larger tumors greater than 3 cms. But what you'll see is for these small seminoma tumors, the risk of relapse is about 10 to 12%, and you don't see any delayed relapses beyond 5 years. On the contrary, for T1B primary seminomas, or those greater than 3 cms, the risk of relapse is a bit higher, about 20 to 22% over time. And also note that there are some patients that can have some delayed relapse. But regardless, because most seminoma patients have an excellent outcome, no doubt surveillance is the preferred management strategy. We just have to know what to do when these patients recur. Now, for non-seminoma, the most important risk feature is the presence or absence of lymphovascular invasion. And if LVI is present, about 40 to 50% of patients will relapse on active surveillance, compared to if LVI is not present, it's about 15%. There are other risk features identified as well, to include pure embryonal histology. And from this Toronto study again, you'll note that of non-seminoma patients, about 65% fall into this low risk category, with around a 15 to 17% risk of recurrence over time. These are the stage 1A patients without LVI, for instance, and who do not have pure embryonal carcinoma. On the contrary, we can look at other risk groups. These include stage 1B patients with lymphovascular invasion, or even stage 1A patients that have pure embryonal carcinoma. And about 40 to 50% of these patients will relapse over time. So this is a risk-adapted strategy in terms of predicting who's going to relapse. So for the stage 1A patient, you and I've cured about 85% of those patients with radical orchiectomy, so surveillance is preferred. On the contrary, if they have LVI or other risk features, yet no metastatic disease and normal markers, then any of these management strategies are deemed optional at this point in time to include surveillance. So when does relapse recur, or when does relapse happen for patients on active surveillance? This is a really nice study that puts all this into perspective, published 6 years ago, Christian Kohlmannsberger and colleagues. It's a multi-institutional study looking at stage 1 seminoma and non-seminoma patients from several institutions, to include the Swedish and Norwegian Testicular Cancer Study Group, the Toronto group, Pacific Northwest and Vancouver group out in North America, and 2 sites in the UK. And you can see hundreds of patients with both seminoma and non-seminoma. In this particular study, of the non-seminoma patients, 16% had lymphovascular invasion and 82% did not. In terms of relapse, if you had lymphovascular invasion, 44% of the LVI positive non-seminoma patients relapsed, 14% of the LVI negative non-seminoma patients relapsed. And of all the seminoma patients, regardless of the presence of or absence of any risk feature, the risk of relapse overall was about 13%. Now, when does relapse recur for all of these different patients? Seminoma patients or non-seminoma patients with lymphovascular invasion or without lymphovascular invasion. The median time to recurrence for these patients, if they have LVI positive disease, is around 4 months. If they have LVI negative disease, 8 months. And for the seminoma patients, regardless of risk features, it was about 14 months, so a little bit longer. Now, in terms of timing for the overall population of patients, note that 99% of relapses occur within the first 3 years. In fact, of the overall group, 1% of patients in the LVI positive, LVI negative non-seminoma, and then the seminoma patients, 1% would relapse beyond 3 years. If you look at the patients that relapsed, however, there are delayed relapses. So in the LVI positive patients, 2% of patients that were destined to relapse did so beyond 3 years, compared to 7% in the LVI negative patients, and 8% of the seminoma patients that relapsed did so beyond 3 years. Where does relapse recur, or how do we detect it? Again, the method of detection, or the first detection for LVI positive patients, usually are going to be identified with elevated tumor markers. In the LVI negative non-seminoma patients, it's about half and half between cross-sectional imaging and tumor markers. And of course, for seminoma patients, we don't follow tumor markers by and large. So the majority of patients are going to have relapse detected with cross-sectional imaging. Fortunately, when relapses occur, the significant majority of patients, in fact, 94%, 88%, and 99% of non-seminoma and seminoma patients relapse with good risk disease. What treatment is delivered at that point in time? For chemotherapy, about 90% of patients with non-seminoma will receive chemotherapy because of tumor marker elevation or disease outside the primary landing zone or bulky metastatic disease. Only about 2/3 of the seminoma patients receive chemotherapy. In terms of radiation, about 1/3 of the relapsing seminoma patients receive radiation. And with primary RPLND, it's about 10% of the non-seminoma patients and less than 1% of seminoma. That may change, though, based on some ongoing and emerging data as it relates to low volume relapsing seminoma. Those patients might be good candidates for RPLND. So what do we do for these relapsing stage 1 patients? Well, we restage them similar to their original presentation. Their outcomes are based on their prognostic group. Fortunately, the majority have good risk disease. Remember that they're treatment naive, so their tumors are and remain chemosensitive. And management is going to be dependent upon clinical stage and serum tumor marker status. So primary RPLND, absolutely a great option for low volume stage 2 disease if those patients have normal serum tumor markers. Induction chemotherapy, though, is preserved or recommended for patients with elevated markers or disease outside the primary landing zone, or of course, if they have bulky metastatic disease. Now, this is a video of a robotic assisted right template for a patient that actually did relapse early on. He had T2 pure embryonal with normal markers, but elected surveillance. In his initial surveillance imaging studies, right at about 4 months, demonstrated disease in the intra-aortic cable region. So here is the CT scan for this patient. He had 2 right-sided renal arteries. You can see a small 12 to 13 millimeter node in the upper intra-aortic cable region. As we move down, another node in the lower intra-aortic cable region. That's all of the disease that we see on this particular CT scan, nothing else. So we've put the patient in a left modified lateral decubitus position, and we've mobilized the colon, cochlearized the duodenum, and now beginning to split and roll over the inferior vena cava. From a minimally invasive perspective, I would say that it's absolutely critical to mimic open techniques. We don't want to salvage the efficacy and the therapeutic efficacy of surgery just by using minimally invasive surgery. You can see a small gonadal artery there. We know that this patient here has 2 right-sided renal arteries. So this is the lower artery, the upper limit of normal there, or the upper limit of dissection. We're taking down some of the lumbar vessels here with a vessel sealer. From a primary minimally invasive perspective, it's absolutely critical to mimic open dissection. And when patients recur, they tend to do so because you and I are not as thorough with our dissection. So it's critical to disengage the great vessels, particularly in this low volume stage 2 setting. Now we're removing here the superficial intra-aortic cable nodes, but we've got to come back and get these deep intra-aortic cable nodes. You can see the postganglionic sympathetic nerve fibers there surrounding one of the lumbar veins too. So this is just demonstrating that we're separating all this away. We're going to divide these lumbar vessels here between silk ties. You could suture ligate those. You could use the vessel sealer. I didn't want to use the vessel sealer in the event that I might injure those nerve bundles, which we're trying to preserve and which we should preserve in most primary settings. So you can see that this vena cava is being disengaged. We're going to resect these intra-aortic cable nodes. It's important to assure lymphatic stasis as well. Those of us who've had to manage lymphatic leaks and chylus leaks, they can be problematic. We know that, but we see the anterior spinous ligament here underneath the cava and in the intra-aortic cable space, letting us know that we've resected those deep nodes along with nerve preservation. Now, there's right to left crossover. So I also believe it's important to get these left periaortic lymph nodes above the inferior mesenteric artery. We've resected these. You can see I'm putting clips at the boundaries of a dissection here. All these nodes have been resected at this point. No intraoperative complications, a nice dissection. This patient had in the hospital for 2 days after surgery, no complications. He's about 2 years out. I think we did his case in 2019, and he and his spouse now have a newborn. So nerve preservation did work in his case. He had 2 of 15 lymph nodes positive for embryonal carcinoma and teratoma and was observed and has had no evidence of disease recurrence since. Now, what happens in that setting when you've administered systemic chemotherapy? Let's look at relapses under those circumstances. So a complete response following chemotherapy is defined as normalization of tumor markers, no residual mass, which would be a true complete response, or a residual mass less than 1 cm in size. About 70% of patients with metastatic disease who receive first-line chemotherapy actually develop a complete response. Now, management can be controversial to some degree, as some would offer RPLNDs for all those patients, although we tend to follow patients who have a complete response. In 2010, there were 2 companion articles. I'm only going to show you one. This is out of Indiana, evaluating patients who have a CR following chemotherapy. 141 patients, 15 years follow-up, all had a complete response following first-line therapy. Relapse occurred in almost 10% of patients. And in fact, some of those relapses were delayed, meaning greater than 2 years following a complete response. The median time for all those relapses, though, was about 11 months. The most common histology in this group of patients was viable germ cell tumor, and none of their patients actually had just pure teratoma. In terms of oncologic outcomes, for the true good risk metastatic patients, cancer-specific survival was 99%, and for the intermediate to poor risk patients, cancer-specific survival 91%. Only the risk classification was predictive of relapse. The retroperitoneal mass size and the presence or absence of teratoma in the primary tumor was not predictive. Now, when you have a patient who has a complete response following systemic therapy, you really often are going to end up using multidisciplinary treatment strategies, particularly in a late or a very late setting, and I'll show you some examples. In the very late setting or late setting, when patients have already had chemotherapy, their tumors often are chemo insensitive. So initial surgery is preferred when a complete resection is achievable, and all sites should be resected due to the possibility of histologic discordance. If they're marker negative, it usually reflects teratoma, but remember, malignant transformation in this setting is not uncommon, but about 80% of patients have viable non-teratomatous germ cell tumor, and it's important to achieve a complete resection because oftentimes this tumor is chemo insensitive. Salvage chemotherapy alone rarely cures patients. It may downsize tumors and facilitate surgical resection, and these are some salvage chemotherapy regimens that can be used, but primary management in this circumstance is surgical. So here are a few case examples. This is a 25-year-old man who in 1991 had a left radical orchiectomy for mixed germ cell tumor. He had metastatic disease, received BEP ×4 chemotherapy, and experienced a complete response. 17 years later, has back pain. Imaging reveals left periaortic and retrocrural mets. He has a biopsy, and the biopsy suggests malignant transformation. We don't treat him with chemotherapy up front. Here are his preoperative CT scans, fairly bulky retrocrural disease, smaller volume left periaortic disease. We resect all of this. The take-home message here is that with malignant transformation, his adjuvant or postoperative chemotherapy is now tailored to his malignant phenotype, and he received FOLFOX chemotherapy for 6 months due to the presence of the adenocarcinoma elements. He was lost to follow-up in 2011, but was NED at that time. Here's a second example. Age 23-year-old man who was now an emergency room physician, but at a younger age underwent a right radical orchiectomy for a pure embryonal germ cell tumor. Markers revealed metastatic disease with elevated AFP, received 4 cycles of BEP, and then experienced a complete response. 25 years later, now a physician, has CT scans for intermittent abdominal pain, found to have a partially obstructed right kidney, possible occlusion of the IVC, large bulky disease with mild elevation of the AFP. Here is imaging studies. You can see bulky disease, infiltration of the right kidney. We don't really see the IVC here. Importantly, we see possibly some involvement of the duodenum, but more importantly, we see venous collaterals. That likely tells us the IVC is compromised significantly and there's low to minimal flow, if no flow. So we see venous collaterals. Also here, this is the inferior mesenteric vein. Oftentimes we see venous collaterals in the deeper in the retroperitoneal space, but the presence of the collaterals helps us establish our surgical plan. We're going to split and roll over the aorta, gain control of the IVC below the left renal vein, and resect all of this on block to include the inferior vena cava based on what we see radiographically. Now, this is not this patient, but this is how I set these patients up from an open perspective in the bulky setting. I use a Thompson retractor, which provides a lot of versatility and exposure. So we've disengaged the bowel and packed that on the anterior chest wall here. Now, this is this particular patient. We split and rolled over the aorta, gained access here, gained access and control of the infrarenal IVC. This is the left renal vein, and our plan is going to be resect all of this disease on block. We've done that. We've divided the inferior vena cava here below the left renal vein, and we're elevating this off of the posterior abdominal wall. Actually, resecting the vena cava here makes this a much more straightforward and easier operation in my mind, and this is the complete resection with the ligated and suture ligated IVC in this location. So unfortunately, his outcome was not as good. In 2011, he underwent this surgery. We also had to use an omental flap because of repair of the duodenum. We felt his resection was complete, and his pathology revealed necrotic yolk sac tumor. We gave him adjuvant TIP, Taxol ifosfamide and cisplatin chemotherapy, but he experienced an early metastatic recurrence, refractory to salvage therapies, including a stem cell transplant, and unfortunately died 15 months following surgery. Here's another example of a man that we operated on just a couple of months ago. He's 42, 4 years ago, had what was believed to be pure seminoma in an orchiectomy specimen, and obviously it was not, but he had was put on active surveillance, and then at year 4 came back in with bulky metastatic recurrence. You can see pre-chemotherapy disease here on the coronal study, pre-chemotherapy involving the aorta, possibly the IVC on the axial study. He gets chemotherapy 4 of BEP, and we appreciate involvement of the duodenum. We don't see flow here in the cava, but we also don't see the venous collaterals here deep in the retroperitoneum along the vertebral bodies, the abdominal wall, the retroperitoneal structures, etc. So in this case, contrary to the other, we have to plan for the possibility of an IVC graft. We expose him. Here's the left renal vein, and indeed, he had involvement of the duodenum here, so we had to repair that and place an omental flap underneath the bowel and between that and the great vessels. All of this was resected. Fortunately, we were able to preserve his cava, although some tapering, had to repair his aorta a bit. This is his pathology revealed 98% teratoma, 2% seminoma, but without malignant transformation. Because he had such small volume of viable germ cell tumor, we're not offering him or recommending postoperative chemotherapy. He did get a post-op CT scan because he had a low-grade bowel obstruction, but that resolved with very conservative management. So when we're doing these bulky cases, post-chemotherapy, or certainly in a delayed setting, you and I always have to be prepared to do additional procedures. Pulmonary and mediastinal resections, which are often staged, retrocrural dissections, liver resections, be prepared to place a graft or resect a cava, bowel resections. Of course, we're all familiar with the possibility of performing nephrectomies. Here's a few examples. This particular patient did not have collaterals and required an IVC graft. Sometimes an aortic replacement will have to be performed as well. This is a patient with a bulky periaortic disease, but you can also see that he has involvement of 2 levels of vertebral bodies. All of this has to be resected. We resected his bulky disease, and then the neurosurgeons had great exposure to come in, do vertebrectomies, excise the disease in his back, place the cage here, and he had great stabilization of his back and pain control actually in the postoperative setting. I preach to our residents and fellows studying vascular and venous anatomy for surgical planning. This is an example of a patient we operated on last year, a bulky disease involving the left renal hilum with tumor thrombus. So we know we're going to take this left kidney, but he also has multiple vessels involving his right kidney. In fact, you can see vessels coming off the common iliac arteries to the lower pole, there and there. He has his main renal artery here superiorly. So that aids us in surgical planning. Here are his intraoperative photos. If you can appreciate this, you can see the tumor thrombus here in the left renal vein. It's pulsatile. We've initiated this dissection, splitting and rolling over the aorta, over the vena cava, and our plan will be to resect all of this en bloc, just like we would a left renal mass with IVC thrombus. But we also have to preserve these vessels here going to the lower pole of the kidney, as well as the right renal vessels. Here's the completed dissection with preservation of the lower pole vessels, resection of the left tissue, the left kidney, the mass, the IVC thrombus, all en bloc. Here's the thrombus here in the vascular structure. Again, had a great outcome and is without evidence of disease now about 14 or 15 months out. And here's the final case. Just illustrates some of the things to be prepared for. This young man had a left radical orchiectomy in South America. No follow-up, presented to us here in the US several years after his radical orchiectomy. And if you can appreciate this neck mass, you know that his abdomen's probably going to look a lot worse, and it did. This is very bulky disease within the abdomen. This is following chemotherapy with really no response, so we suspect this is teratoma. We knew that we were probably going to have to take his left kidney and work to preserve his right kidney. And I'd say in the bulky setting, when you see teratoma here in the bowel mesentery, not a good sign. Oftentimes it's hard to completely resect all of that. We took him to the operating room, resected him. We can establish these tissue planes, although it's markedly challenging. You see multiple pledgets here on the anterior abdominal wall. We had to resect the left common iliac vein, had to divide the right renal arteries and graft those back into the mid aspect of the aorta, of course, in working with one of our vascular surgeons. Here's an up close, multiple entries here into the aorta, and two renal arteries here actually grafted together and then grafted back into the aorta. He stayed in the hospital about 4 weeks, had a chylus leak. We removed this teratoma as well. Ultimately was lost to follow-up. So in conclusion, late relapse on active surveillance, generally these patients have an excellent prognosis, and fortunately a significant majority of patients, when they relapse on active surveillance, have good risk disease. You and I want to stage and manage these patients accordingly. I think that's generally straightforward. Now, the patient that relapses following systemic therapy, including those that by definition, late relapses beyond 2 years and very late beyond 5 years, cure is possible, albeit these cases are often very challenging, often requires a multidisciplinary approach. In the setting where they've already had systemic therapy, primary management is surgical, as tumors tend to be chemotherapy insensitive. So a complete resection is critical because they often have viable germ cell tumor. Survival can still be accomplished, although it's generally less than what we'd see in a standard post-chemotherapy setting. Listen, thank you very much. I hope you enjoyed the presentation.
Thank you very much, Dr. Sexton. Again, amazing talk and great surgical skills. I mean, some of those images which you showed and the way you have dealt with them, once you see them, your heart really sinks once how you're going to tackle with them. But I think a few things which you mentioned, that what you tell your trainees is to go through the scans and the vascular anatomy in detail is very important. And secondly, have a multidisciplinary approach. I think there was a question about it, which you answered. So it's really important that you have your skills right, you've got your planning right for the day. So I really appreciate that. For the sake of the time, we're going to move on to the next talk, and we'll come back to the question answer session again at the end. And meanwhile, we'll answer them online as well. Our next speaker is Professor Hamad Attar. Thank you very much for being with us this afternoon. Prof. Attar is a professor of urology at Al University Hospital, Karachi, a well-known name in the Uro-Oncology in Pakistan as well as abroad. His area of interest is renal cancer as well as prostate and bladder cancer. He probably has got one of the larger series of the radical cystectomies and reconstructive surgery in terms of the new bladder. And that's what we are going to learn from him today in terms of the managing complications following orthotopic new bladder formation. So over to the Prof. Attar's talk, and then we'll come to the questions.
Right. First of all, I'm really grateful for the organizers for this very kind invitation. So I'm going to address upon the topic of open orthotopic new bladder and the complications and how you manage. So it's part our own experience over the last more than 20 years and the experience of the world. We know that radical cystectomy is the gold standard in the management of muscle invasive bladder cancer, which is not locally advanced, meaning that it has not gone to the pelvic side walls, without nodal and metastatic disease. And it is also a gold standard for non-muscle invasive bladder cancer in situation where you have a high risk recurrent tumors, you have BCG refractory disease, or there is extensive papillary disease which cannot be controlled by TUR and intravesical therapy alone. When radical cystectomy be done, and there is a very good quality data available to show that if you do it within 3 months of the diagnosis of muscle invasive bladder cancer, the chances of survival improve significantly. And if it is after that, then again, there are issues. The question, what should be done? And we know that a standard radical cystectomy in men is cystoprostatectomy, along with nodal dissection, at least standard. And in female, it is anterior pelvic exenteration. Now, genital organ preserving radical cystectomy has also been described. If you look at the guidelines, it is clear that genital preserving radical cystectomy for both men and women should only be offered to patients who've got an organ-confined disease, and it is proven on histopathology and imaging. And also that the men and the patient himself is keen and motivated to preserve the genital organs. So, however, both for men and women, the standard treatment is to offer non-pelvic organ sparing radical cystoprostatectomy for both men and women. We know that robotic-assisted radical cystectomy is gaining popularity, and there are quality studies and data available to compare the two. Well, the radical cystectomy robot-assisted is a bit longer and takes about 1 to 1.5 hours longer than the open radical cystectomy. Obviously, it's associated with significant additional cost. However, the hospital stay is reduced by 1.5 hours, and there is less blood loss compared to open radical cystectomy. The major complication rate in the two are very similar, so there is no major advantage in terms of high cleaving rate complications. The intermediate oncological outcome of open versus robotic assisted procedures are very similar, so there is no added advantage. The most important thing, however, is the surgeon in the center performing these procedures and their familiarity in dealing with patients who've got muscle invasive bladder cancer. We know that since the EORTC-MRC study, in which it was clearly shown that there is 5 to 8% overall survival benefit if the patient receives neoadjuvant chemotherapy, which is cisplatin-based. And in those studies, MVAC was basically used. So it is standard to do neoadjuvant chemotherapy. However, things have changed over the last 1 decade. We know that radical cystectomy can be performed more safely now with less complication rate. We know that there are certain disadvantages of neoadjuvant chemotherapy, which includes delay in treatment and lack of response in significant proportion of patients. And based upon the current regime of chemotherapy, which is not MVAC, but gemcitabine and cisplatin, patients who are not eligible for cisplatin-based therapy should not be given neoadjuvant chemotherapy. And neoadjuvant immunotherapy is only given in trial settings. One of the most important component of radical cystectomy is the lymph node dissection. The standard lymph node package, which includes from bifurcation of the common iliac over the external iliac, artery and vein, between the artery and vein, going into the obturator fossa, removing all the lymphatics from the obturator fossa, and then the lymph node related to the internal iliac and going medially all the way up to the median sacral. So these lymphatics are important to be removed. If there is any reason or clinical indication, extended or super extended lymphadenectomy can also be performed. Following cystectomy, diversion is done, and there are 3 basic types of diversion. Abdominal diversion, which is continent or incontinent. The incontinent abdominal diversion in the form of ileal conduit is the most frequently performed surgical procedure. It is performed in over 90% of patients who undergo radical robotic assisted procedure, and significant proportion of open procedures, open radical cystectomies as well. Urethral diversion in the form of orthotopic new bladder is the in thing. It is provides a high quality of life, and there is no need for abdominal stomas. Rectosigmoid diversions are very infrequently performed these days. We know that men who undergo radical cystectomy along with orthotopic new bladder are associated with significant complication rates, and these complications the mortality can be up to 1 to 3% in first month, and about 2 to 8% in the first 3 months. The major complication, the early complications in major series is up to 50%. So, and late morbidity is typically related to the divergence. So the diurnal and nocturnal continence is seen in about 90 to 70% of patients. So nocturnal continence is seen about 20 to 30%. Urothelial, ureterointestinal anastomotic strictures, metabolic disorders, and vitamin B12 deficiency are some of the other major long-term complications, which are all divergent related. If you look at our own 15 years data, over 300 cystectomies, vast majority of these patients had ileal conduit. As you can see, that 250 plus patient had radical ileal conduit, and 52 patients had orthotopic new bladder. 50 in the first time, and 2 patients with ileal conduit were subsequently converted into orthotopic. Cutaneous continent cutaneous diversion in the form of Indiana pouch and cutaneous ureterostomy is performed in a small proportion of patients. So in order to preempt complications and in order to control these complications, it's important that you select the right patient, and the right patient should have the right disease, which is local or minimally locally advanced, plus minus N1 lymph nodes. Patient should be appropriately prepared for these procedures and counseled. It's important that no previous bowel resection should have been performed in these patients, because compared to an ileal conduit of 20 centimeters, we take about 55 to 60 centimeters of ileum for orthotopic new bladder. Significant liver dysfunction and kidney dysfunction are contraindications, so as the continence. If there is an issue with continence prior to surgery, again, these patients would not really benefit from. People who have got recurrent urethral strictures, and more importantly, patients who have got poor compliance, because these patients, orthotopic new bladder is really a responsibility for the rest of your life. So it's important that the patient understand what he's getting into. So long-term follow-up is essential. Adequate physical dexterity in terms of being able to perform intermittent cath, which is required in a small proportion, but maybe in the first 3 months it is something that is needed, particularly for the mucosal, the mucus which gets impacted. Recurrent urethral stricture again is a contraindication. Pathologically, it is important that no more than in 1 patient be, and that too in a very select group of patients. So patients who require further treatment to the pelvis should really not undergo radical cystoprostatectomy. Perioperative findings sometimes contraindicate use of orthotopic new bladder, and this particularly includes short mesentery or rectal injuries. So it's important that patients should be counseled for ileal conduit, all patients who are even planned for orthotopic new bladder. If there is paracollicular biopsy which is positive on the day of surgery, again, that's a contraindication. So how do you prepare your patient? The bowel prep should be minimal. We are using small bowel, and you don't really need to do extensive bowel preparation, which causes electrolyte imbalance, fluid imbalances, which is not really required, and that can increase morbidity of your patient after surgery. So minimal bowel prep is what is. Colonic enema are again important, because you need to have a prepared rectum in case if there is any rectal injury. You can really do a primary anastomosis rather than giving him a colostomy. Education and counseling of patient, particularly counseling them about post-operative recovery, what are the problems they're going to face, is extremely important, and your nurse should be trained to actually do it. Medical optimization, again, something that should be done before any major surgical procedure. DVT prophylaxis is again important. pelvic surgery for lasting for even up to 4 or 5 hours is at high risk of developing deep vein thrombosis. Antibiotic prophylaxis, injectable antibiotics for the first 3 to 5 days, and oral should continue as long as you have not removed all the tubes and drains. Well, post-operative management to allow quick recovery and following ERAS protocol is now very well established. We remove the NG tube on immediately post-operatively or in the recovery room. Pain control, we like to avoid the narcotics and give them a TAP block as well as oral paracetamol along with carbapenem. Nausea and vomiting prevention is important so that they don't, they can start alimentation early. Alias prevention. Alias is one of the major problems that delays discharge of these patients, and Alias prevention is important. Use of albumin, which is prescribed in the ERAS protocol. However, it's not available in Pakistan, and we tend to use neostigmine. And we avoid epidural anesthesia, so the patient can be mobilized early. And typically, our patient mobilized bed to chair on the first day. Our recent protocol in the EAU meeting was awarded first prize with 2,500 grant to conduct nurse-led ERAS protocol in our radical cystectomy patients. This is our data reported a few years back, in which the perioperative complication rate was 1 in 4 patients. The continence was quite good at 6 months. Over 90% patients were fully continent. The 1-year continence rate was again over 90%. The mean bladder capacity is extremely important, and that should be carefully controlled because these ideal bladders have a tendency to become bigger and bigger if you have hypercontinence. So about 400 ml is what is optimum, and these patients should not have more than 450 ml because that makes the bladder really floppy. If you have less than that, then you will have problem with continence. The late complication rate is 1 in 5 patients, bladder neck contracture, bladder stones, incisional hernias. Over 80% of our patient has a preservation of their renal function, and the survival rate at more than 5 years follow-up was over 80%. So what are the grade 1 Clavian complication? And Alias, as I said, is the most commonest. You need to take the NG tube out as early as possible, start them with chewing gums, and we give them chewing gum on the first day after surgery, and by second day, they are given yogurt and tea. Use of antiemetics, as I said, it's important that the urethral catheter should not get blocked. So on third day, when the intestine starts to work, that's the time that they should have some form of bladder irrigation. If there is any intra-abdominal urine leak, the drainage tube should be checked, and they should be on continuous drainage. Partial treatment for anemia. For late grade 1 complication, mucus cock is one of the commonest, and they should be really taken care of by either intermittent catheterization and bladder flushing, or using cough to move out the mucus cock. Incontinence, again, it's important to see the bladder capacity, post-void residue, exclude urinary infections, and physiotherapy. So for hypercontinence, patient may require either drainage or intermittent catheterization to keep their bladder nearly at 400 ml so that the hypercontinence is avoided. If the anemia is badly tolerated as a Cleveland grade 2 complication, transfusion, pulmonary embolism should be avoided. And it's important that they should be on anticoagulant at least until the time they're fully mobile, but first 1 month is really critical. Of the grade 3 complications, the urethral catheter, which get accidentally blocked, and that's a major issue. These are precious catheters. Sometimes we pass a thread through the eye of the catheter, which comes out on the anterior abdominal wall, and these catheters can be pulled back. Anastomotic stenosis taken care of by renal drainage, and reflux is something that you really don't need to bother too much about, as it does not have long-term implications. If there are ileal anastomotic leak, you would require ileostomy and really take care of their fluid and electrolyte balance and diet. For grade 4 complications like rupture of the new bladder, nephrostomy and indwelling catheters are important, and they would probably in the majority of situations be able to be managed conservatively like this. But if they don't respond to the conservative treatment, the only treatment is to go on and repair the new bladder holes. Non-obstructing acute kidney injury, it's important that you take care of their bicarbs and electrolyte balance. If there is an obstructive pyelonephritis and septicemia, nephrostomy tubes and antibiotics is what is really required. So this is one of our patient who was referred from Quetta for an orthotopic new bladder. He underwent an unremarkable radical cystoprostatectomy, and an orthotopic new bladder was made. He was doing quite well until the first 5 days of surgery, and subsequently he developed abdominal distension. CT at that time was quite unremarkable, and as you can see that there is no significant collection. However, he continued to deteriorate and had some fecal discharge from his drain. At that time, he was explored, and there was a small hole in the ileal anastomosis posterior wall, which was repaired, and an ileostomy was made. During that time, a JP drain was placed, and on the 3rd day after the ileostomy, he started to pour significant urine from his drain site, and accidentally what has happened that the drain has gone into the has damaged the wall of the orthotopic new bladder. Nephrostomy drainage was started, and this patient has recovered with conservative treatment, and it's a good thing that we didn't need to go in and explore him again. So these are geriatric patients who can develop significant complication. It's important that the complications are preempted and the domino effect is averted. And thank you very much for your attention. I'll be very happy to answer any questions.
Thank you very much, Professor. Again, very interesting and eye-opening talk. These surgeries are never easy. These are difficult patients. These are complex surgeries. We've got a few questions, and we're going to straight away go to them so that for the sake of time, we can conclude the session. There's a question by Yasser. In your experience, any other specific consideration, contraindication in our population before offering a patient orthotopic new bladder opposed to Western populations? So do you find it difficult to counsel the patient regarding that orthotopic new bladder in your practice, Professor?
Yeah, thank you very much. So one of the important thing is that these patients should be willing, and you can see that they are going to follow you for years to come, because they have complications related to the orthotopic new bladder, which can last years after surgery. So be compliant is one of the most important things. In the initial phases, they should be willing to do clean intermittent self-cath or learn that, or some family member learns that. If they're not willing for that, that's again a complication. Some of our patients come from far off places, so their ability to come for regular follow-up and be able to do all the necessary workup is extremely important. In our own cohort, the recurrence rate of cancer is low because your patient selection is good, and these are mostly confined diseases, but their metabolic complications are significant, and particularly the metabolic acidosis related, bone related complications, etc. So the regular follow-up and be compliant with the follow-up is my major difference from the centers in West, where they probably will get the surgical procedure in their own city rather than coming to Karachi from far off areas.
I think that's correct. I mean, dynamics of the patient population are different compared to the Western countries. So thank you very much for that. Maria, your question next. We can't hear you, Maria. Can you unmute yourself?
Can you hear me now? Yeah.
Yes, we can.
Sorry. So there was one of the questions from one of the attendees in the question and answer session for Prof. Rob Jones. Rob, it's so pleasant to see you in the session. So you said that you would be answering it online in the live session. So the question was that, is there any difference between immediate adjuvant chemotherapy versus deferred one in patients who underwent cystectomy for muscle invasive disease, especially who are not able to receive new adjuvant chemotherapy? How do you see the difference in overall or disease-free survival, and which approach do you prefer?
Yeah, so I think this is a really important question, particularly when we're looking at the Checkmate 274 data for nivolumab, because of course, what we really aim to achieve with perioperative chemotherapy is not just a delay in relapse, but actually an improvement in the overall cure rate across cancer. That's what neoadjuvant chemotherapy or adjuvant chemotherapy is about. And so, of course, there's a reasonable challenge that if all you're doing is deferring treatable recurrence, are you really, bearing in mind there will be a large group of patients who will have treatment unnecessarily, that is those who were never going to relapse, are you really achieving a satisfactory goal for these patients? Put it another way, is disease-free survival actually a valid endpoint for adjuvant chemotherapy trials? So my feeling is that actually we really need to understand, at least, is there a trend towards an overall survival gain, so that we can actually advise our patients that the cost in terms of toxicity, which may include financial toxicity, of course, really does actually justify the use of this treatment. I'm prepared to accept disease-free survival as a primary endpoint, but we need to be able to at least advise the patient as to whether or not that is likely to translate forwards into an overall survival effect.
Right. Okay. We're a bit short of time. So just a brief comment from you, Dr. Sexton. Again, one of the questions from the trainees was earlier asked. Once a young consultant or a trainee wants to embark into this RPLND surgery, any particular considerations of multidisciplinary team approach? Any final comments on that from you, please?
No, that's a great question, and I think the same would apply to if you're a very busy bladder cancer service, and Dr. Arthur may agree in the sense that that anybody who's doing some substantial operation is going to run into complications, no matter how experienced you are. So surrounding yourself with trustworthy colleagues with a similar goal in mind, that is to offer the patient the best outcome possible, is important. From a testis cancer perspective, absolutely. You need a group of like-minded surgeons, thoracic surgeons, vascular surgeons, surgical oncologists, colorectal surgeons, because neurosurgeons, anything is at risk from the testis cancer perspective. So in order to, I think, and you mentioned this, Dr. Chima, the best thing is to plan and be careful in your preoperative planning, your preoperative assessment, surrounding yourself with a surgeon colleagues who can share in that outcome and share in that patient is really important. And as your experience grows, then you'll know when to preoperatively bring those patients, or those physicians in as part of that case, rather than bringing them in a hasty fashion in the midst of a complication. So I think that's very important and wise for the junior surgeon.
Thank you very much, Dr. Sexton. And with this, I would like to conclude our session. I would really like to say thanks to Prof. Jones, Dr. White from Scotland, Dr. Sexton.
Excuse me, Dr. Chima.
Yes, please, go ahead.
I think we have few questions for Dr. White.
I think we're probably running out of time. Will it be possible for Dr. White to answer them online? Because our next session is starting straight away, I'm told, on the same stream.
I'm happy to receive questions.
There are actually loads of questions, but it's just the time is a bit of a limitation here on this end today.
Yeah, I'm happy to receive them via this system or email if I can help. Thank you.
That's very kind of you. That's very kind of you. And again, thank you very much to all the panelists, and thank you very much, Dr. Maria, for co-hosting the session with us. Thank you very much.
Thank you.
Thank you.
Thank
Goodbye.
you.